So now we're going to move to Professor Xavier CAPDEVILA from Montpellier in France, who's going to talk about postoperative pain after total knee replacement.
Thank you, Hélène. So pain management after total knee replacement is quite a puzzle because we have so many techniques now, and we imagine probably that every kind of techniques it's more efficient than the other one. So in fact that probably we have to customize or to personalize what we have to do on the patient now. So when we see what happens concerning the last paper published in Anesthesiology that year, this paper clearly claim that if you have to choose one of the postoperative analgesia regimen, you have to choose first the multimodal analgesia regimen, which is quite mandatory and quite obvious. And after, if you have to choose one kind of regional analgesia regimen, it seems that the use of continuous peripheral nerve blocks still stay at the first place of the interest of the regional analgesia techniques. Clearly, in this paper, the authors claim about the interest of rest pain, passive range of motion, and opiates consumption. This is probably one of the most important factors that we have to keep in mind for these patients. But probably these factors are not as efficient as the majority of the factors we can have for optimizing the postoperative analgesia in the total knee replacement. And this is why the group of Brian Ilfeld and colleagues demonstrated recently that obviously we have to decrease pain, we have to decrease the cost and hospital length of stay, but we have also to improve some parameters very important for the patient and for the institutions, so it means for the classical hospitals or private clinic institutions. And we have finally to improve the patient satisfaction and to decrease the incidency of chronic pain. The other very important point is that when you see exactly what happens in the USA concerning the use of PNBs, unfortunately, because for me it's unfortunate for the patient, only 20% of the patient receive regional anesthesia techniques for a TKA in the USA. Well, what about the kind of regional analgesia technique without PNBs we can use in this patient? Clearly, and you know this is probably a sort of fashionable management, we have to use now the LIA. LIA, it's a local anesthetic infiltration in this patient. You know that you have to put on the knee of the patient around 200 mL of a solution of local anesthetics, NSAIDs, and in some way opiates and steroid molecules. And we have, as a result, that classically we optimize the pain analgesia, the postoperative analgesia in this patient, mainly from 0 to 24 hours. After 24 hours, it's a little bit more challenging to obtain with this kind of postoperative regional analgesia management. It's more difficult to obtain a real good pain relief in this patient. So we can use that, but we have probably to use that in a multimodal analgesia regimen with probably other kind of techniques, has probably different kind of PNB or neural blocks. The other possibility is to use in the same way not only local anesthetics and steroids, but also, for instance, the use of these famous extended release liposomal bupivacaine, so in other words, Exparel in the USA. To be honest, unfortunately, despite the price, that it is very different from the classical bupivacaine, the last findings does not justify the routine use of liposomal bupivacaine in the LIA regimen in this patient, because as you see here on that slide, the results are not really different from the classical bupivacaine. So what we have to do, the more recent block is the use of continuous adductor canal block. So adductor canal block is is a new block that you can do in the adductor canal. And when you do that, classically, you anesthetize the saphenous nerve and the vastus medialis nerve, as well as some branches coming from the obturator nerve. If you do that, classically, you can have the same level of pain relief that normally you can have with a femoral block without any, normally, motor blockade in the patient. As usual, I would say, we have some debate about the usefulness of the adductor canal block, because you see here classically that these studies demonstrate that the adductor block does not promote any benefit over the classical LIA in the patient. And in contrast, in this study here, you see that the adductor canal blockade effectively reduces pain and opioid requirements in comparison with the classical LIA in the patient after total knee replacement. So you see that probably depending from the area of putting a local anesthetic solution, proximal, distal, etc., probably the volume of local anesthetics you use, the kind of local anesthetic you use, etc., you can have some differences for the usefulness of adductor canal blockade. Classically, the majority of the studies demonstrate that the use of adductor canal blockade helps for obtaining more a good pain relief in the patient after a total knee replacement. What about another looking at the patient? And it is very important to look at the patient more individually, because we know that probably we have to customize again the pain regimen, the pain relief regimen that we use in this patient. In this study, it is very interesting to see what happened with the use of the famous adductor canal block. And you see here that clearly there is a difference between the patient receiving the adductor canal blockade and the patient not receiving the adductor canal blockade. But what is very interesting is the individualized curve of the patient. And what these curves showed, these curves showed that probably, unfortunately, with the adductor canal blockade, we have 25% of non-responders. So it means that a quarter of our patients never have a good pain relief if we use the adductor canal blockade. And the other very important results is that almost 80% of the patients still had moderate pain whatever we use, and mainly if we use adductor canal blockade in this study. So it is interesting to see that adductor canal block, it's probably not the magic bullet that we can have in our hands to optimize the pain relief in the patients. So, more modern approach. This is the use of what we said only motor sparing knee blocks. So what it means? It means that motor sparing knee blocks is the use of LIA in the majority of the patient, plus the use of isolated saphenous block and the famous IPAC. What is IPAC? It is an infiltration of local anesthetics in between the popliteal artery and the posterior capsula of the knee. This is a sort of area where you can put local anesthetic, and if you do that, you should normally anesthetize the sensory nerves of the posterior part of the lower limb, so it means coming principally from the sciatic nerve, but without promoting any motor blockade in the patient. So it seems very interesting to see that. We have some studies now arriving in the literature, and the most recent studies demonstrate that clearly if we compare the periarticular infiltration, so-called LIA, in comparison with the motor sparing knee block, we have a more duration of the pain relief in the patient receiving these famous motor sparing knee blocks. And another very interesting study demonstrate in more than 100 patients in a classical case series study that if we use the famous IPAC, and if we adjunct the IPAC to the femoral nerve, probably this is the best way that we have to use concerning the quality of pain relief in the postoperative pain period, but also we optimize the possibility to walk in the postoperative period. So you see the difference. It's better to use ACB, so it means adductor canal block plus IPAC. So it seems better than the FNC alone, quite similar to FNC and IPAC. But concerning the possibility to walk, it's better to use ACB plus IPAC. But you see this difference, it's mainly, honestly, only reported for the first day. So we have to keep in mind that we don't have a huge difference for rehabilitation in the whole postoperative period. So finally, the last slide is to say what we have to do. We have to personalize the postoperative analgesia regimen that we do on the patient. Some patient will necessitate to have a continuous femoral nerve block. Some patient can have some LIA. Some patient would have LIA plus adductor canal blockade or IPAC. And if we know that we have to personalize our regimen. What is very important, we have to include these kind of regional anesthesia technique within a multimodal analgesia regimen in the management of ERAS, so it means enhanced recovery after surgery. And if we do that, you see here that it seems that peripheral nerve blocks intraoperatively are necessary. Probably LIA, it's also necessary. And if you see what happens concerning the postoperative period, you see that continuous peripheral nerve blocks can be discussed to optimize the prognosis as pain relief in the patient, probably again within a multimodal analgesia regimen. This is very important to keep in mind that.
Thank you very much, Xavier, for clearing things up, or at least trying.
Yeah.
Because it's very complicated, right?
I think so. It's not very complicated. So as my friend Laurent Delaunay said, before we have the blocks, and we say that, okay, if we have the blocks, we should do the blocks. Yeah. But we know that the blocks can be problematic for motor blockade, for some things. So now we have the choice. But have the choice means that we are free of using different kind of techniques. And in some patients, it can be difficult. So we have to choose. But I don't have to say that technique is the better one. You know, yeah. If we say that, it's probably problematic for some of our patients. So we have to adapt what we have in our portfolio to put the best management on the table. And probably, I think that we have to use some infiltration and some blocks. It can be the adductor canal, the IPAC, or the FNB, but we have to associate different kind of indications.
So you recommend to associate different techniques, yep. But I'm gonna be the non-expert here because my daily practice is not in orthopedics. What I see is that you use a lot of local anesthetics, infiltration, nerve block. And so, are you worried about total dose and the systemic effect?
From a personal point of view, definitely not. I'm not worried about. But I think that we have to use, for instance, if we use adductor canal blockade plus IPAC, for instance, I have to use around, I would say, 10 to 15 mLs of raw bupivacaine, for instance, in the adductor canal, and probably, again, 15 to 20 mLs of local anesthetics within the IPAC area. So what it means? It means that at the end, we use less than 40. And what we did before, we use probably 40 to 50 mLs of local anesthetics. So it means that we have to mix in between the two areas the use of local anesthetics. And you know, if I have some ideas concerning this kind of topic, my friend Olivier Choquet said, okay, if you manage the concentration of local anesthetics and you know perfectly what you do in our hands, because we are specialists, and we don't have to put that in the hand of the surgeons, definitely. If we do that, we optimize the treatment of the patient, and we know that what is good for the patient, definitely concerning local anesthetics. So no, I don't be worried about that.
So, but talking about IPAC, we have a question here.
Yeah.
Because it's very likable because it's infiltration back in our hands.
Yeah.
So, yes, like you said. So, what do you think about IPAC? Do you use it? Did you try it?
Yeah, yes, absolutely. We use HIPAC in our institutions. We begin to use, to be honest, since probably about 3 to 6 months. So it's clearly a very good location to put local anesthetic. And when you do that, we optimize the mixing between anatomy and results. So what is very important, because if you do LIA, you have to put local anesthetics everywhere in the knee, and some surgeons put also an intra-articular catheter, and we know that putting the intra-articular catheter can promote some infections and some wound healing. So we do not have to do that. But clearly here we specialized and we factualize the injection of local anesthetic just close to the posterior nerve of the lower limb. And we have to associate that with the nerve of the anterior part. So it means vastus medialis nerve, of course, and saphenous nerve. If we associate that, we have the best result for me.
Okay. So my last question would be, finally, what would you recommend? Do we, for analgesia after TKA, do we need to be evidence-based medicine, or do we have to be kind of like patient-centered care?
Okay, it's a perfect question. I think that probably we have to be definitely personalized to the patient. So patient care treatment is the best, we know that. And clearly we have to keep in mind that the patient is the main target, and we don't have to apply the same thing in all the patients. We know that we have to personalize our care in the patient, and this is definitely the patient care management.
Thank you very much, Xavier.